But what about that patient now? We've alluded to this several times. The patient has been through several lines of therapy. Now, part of that is that part of that for sure is disease biology. Nobody gets to fourth or fifth line therapy without having disease biology that is indolent, because, some of this is the treatment effect, but whatever you don't kill, presumably is coming back stronger. And yet these are patients that are able to tolerate that higher tumor burden, tolerate those multiple lines of progression, tolerate those multiple lines of therapy. The patients have to be stronger as well. But you get to these patients, in the sort of third, fourth, or fifth line setting. Any philosophy on how you manage those patients in terms of the treatments? Because, again, our community guys, there's not clinical trials out there. There's guidelines, but there's not really trials. There's not even really guidelines for fourth or fifth line. I mean, it's kind of all lumped together. What do you tell your colleagues? How do you manage it yourself in terms of these patients? Anybody? I'm opening it up. We're getting loose. We're near the end. Anybody, jump in.
I'll jump in and say, with the IO combos being in the frontline space, like whether somebody starts with nivo/ipi or starts with pembro/axi, they're going to get one of those options. And there is data for retreating, post IO, certainly from the fraction trial, from retrospective series, that IO post IO has a response rate around 15%. So, just because you're out of that frontline space doesn't mean you can never give somebody nivo/ipi, or you can never give, yes, there's insurance issues, but if you're fourth or fifth line and they've never seen nivo/ipi, then you could consider that. Or if they're, never seen pembro/axi, or maybe never seen axi, but have seen nivo/ipi, maybe you'd consider giving them pembro/axi. So, that's certainly off-label, like totally off-label. But I think when you're getting into that, fourth or fifth line space, if somebody's already received a IO combo, they've already received Cabo or Len/Ev, thinking about, are you going to just, maybe they've already seen a single agent TKI and you're like, what am I going to do? So I think it's not out of the realm of reason to consider, those combinations. And honestly, I think if somebody is still doing well and you're considering fourth and fifth line, like, thinking about a tertiary care center close by where you can refer for a clinical trial. There's a lot of interesting agents out there that are in testing that have shown promise in early studies, the glutaminase inhibitors, the HIF2 alpha inhibition. There's a lot of exciting things out there that I think is going to also change the second line and post space. And so thinking about those options for patients, I think, is important.
I think we're going to get to that in just one second, but I do want to just bring up, because I think these patients that get to these fourth, fifth line settings, there's one common theme, not universal, but common theme, and that's they almost all have had at some point or another some focal therapy, and maybe for the brain met that Monty mentioned, or maybe for bone met, it may be radiation, it may be cyberknife, it may be a debulking, metastectomy, but or other kind of symptomatic complication. But I feel like for my chronic renal patients that get there, part of that is weaving in when to use those kind of focal treatments. And again, I don't have any trial on this or any data, but just from my own experience looking at my own clinic, I look at those long-term survivors, and frequently it's been a mix. It's been a multidisciplinary care effort to kind of get them those 6, 7, 8, 10 years of metastatic renal cell carcinoma.